one of the most important and high yielding topics, both for your exam point of view as well as in your day-to-day clinical scenario as well in your practice. That is trauma. Yes, we all have come across one or the other way of trauma in our undergraduate life, or during post-graduation also will be coming through. So be it a medical student, dental student, or any medical professional, it's very important and very pertinent to know at least the basics of trauma. Why? Because there will be scenarios where you will be posted alone in a center, and there will be a polytrauma patient comes, and he will have multiple injuries, not just the face or the oral cavity, but he will have injuries in entire body. That time we should be knowing, although there are specialists available, even then what's happening with the body, or what others are doing. At least basics you should be able to understand, and you should be able to cope up with the approach. So that's why I thought let's start with this important topic, trauma. This is going to be a very vast topic in your entrance exam point of view, but I'll make it as simplified as possible for you with the basic and very interesting flow charts with which you can understand better, and it will be a very conceptual session as well as a very crisp one. Okay, so I'll make entire trauma look interesting for you and understand in a better manner. Okay, so I expect a very interactive session with you all. Okay, I'll be looking at the chats in the YouTube's session. So you can post whatever the doubts you have, whatever the questions you have, queries you can post it there. I'll be continuously watching there also. So any point of time, if you come across any kind of doubts, you need any clarifications, or you want me to repeat, please put it in the chat section there. I'm more than happy to explain till everyone understands. Okay, and if possible, although this is a demo class, I don't want anyone to miss out anything. So please keep a notebook in your hand. Okay, I want you all to note down everything, whatever I have written here, because this is going to be very valuable notes for understanding the concept as well as to revise just before the exams. Although surgery is not a major chunk of your question, general surgery is not a major chunk of your question in your MDS entrance exam, but then this makes a huge difference. Whatever the 5-6 questions you get, this, if you get it right, you'll be right with your ranks. But if these questions, if you miss out, this will be like a silly mistakes, and the chances of you getting a good rank goes down. So at least from surgery point of view, I expect you all to get all the questions right, and only the basic questions will be asked. So we'll be well prepared with these. So let's start. You all ready? Okay, please give a thumbs up if you all ready. Okay, so you will be continuously answering there, and meanwhile, if possible, please make a note of it also. Okay, and see, this is not just a general surgery discussion. Meanwhile, I'll be giving overall orientation to how to approach to an entrance exam as well. Okay, so if you learn the basics of general surgery, this will be going to help with your other subjects as well. Okay, so don't think it's just a general surgery, it's not very important to me. No, not that way. Okay, so along with the basics, we'll be learning, getting an orientation to how to deal with any kind of MCQs or any entrance exams for that matter. So can anybody tell me? Yes, thank you Aditi, thank you Dr. Pooja, Dr. Libra, Jyoti Rana. Let's start. So can anybody tell me what's the most common cause for trauma? Can anybody say what's the most common cause for trauma? Yes? Yes, it is. Yes, actually in real life scenario, although for our exam point of view it is RTA, means road traffic accident, in a real life scenario it is emotional trauma. Correct? Very good. Most of them answered RTA. That's correct. Emotional trauma is more common than RTA. RTA means road traffic accidents are very, very common. Other than that, we fall on our own, self fall, or some homicidal. All those are other parts of trauma. But most common cause is road traffic accident. What do you mean by polytrauma? Poly means multiple, right? So polytrauma means one patient having multiple injury, be it head injury, along with it he'll be having a fracture in his upper hand also, he'll be sustained injury to his chest and also lower limb. So one patient sustaining multiple injuries called polytrauma. Then there is a terminology which comes interchangeably in our case scenarios or in your casualties, that is what is mass casualty and what is multiple casualty. Okay, now I'll give an example. Most of our discussion will be along with the example, so that you can relate to your internship days, what you already come across, or you may be working somewhere there also, you might have come across similar things, so you can relate and understand better, you can remember. So you are working in a primary health center, PHC. Okay, now there is a bike fallen, like skid, bike has skid, and two people have fell down and they come to you with multiple injuries, they come to you. Okay, and you are alone, posted in as a PHC officer, and when they reach the center, can you treat them or not? You alone can treat two patients, so yes or no? With whatever the facilities available in your primary healthcare center, they have wounds over their hand and leg, okay, and it is bleeding. Even then, can you manage them or not comfortably? Yes. So when I reach the center, if the facilities are available, okay, if enough or adequate facilities available to treat those two patients, I don't say in general, to treat those two patients at a time for you alone, is it if available, then we call it as a multiple casualty. Same thing, you imagine you are posted there and one bus has fallen down into the valley and 30 patients injured, and they come at a time and barge into your table. Sir, we are all injured, 30 patients, you please treat us. Now what you do? You are alone, and facilities are also not enough to treat 30. There are 30 beds are not available, and you don't have enough facilities to treat all of them at once. Then it is considered as mass casualty. You have to refer them to a higher center where all the facilities are there, enough medical professionals or healthcare professionals are there to take care of all 30 patients at a time. Then it becomes mass casualty. So when facilities are not enough, then you call it as mass casualty. We have in newspapers and all, every day we come across this word. There was mass casualty happened in Himachal Pradesh when a bus fell down into a valley and all. So this is a difference between multiple casualty and mass casualty, which you can handle in your own way alone is becomes a multiple casualty, whereas a mass casualty is when the patients overwhelms the whatever the available facilities in your center. So hope it's clear. Now, when such things happen, where multiple casualties or mass casualties happen, they all barge into your table, 30 patients at a time, they come to you and tell, sir, please treat us first. I have injured here, I got injury here, I got fracture, I am bleeding here, so I can't breathe. So many complaints. How do you go about? You are all alone. So how do you go about? What is your approach? Okay, so the prioritizing the treatment. Priority is the treatment on the basis of severity of injury. You decided whom to treat first, not like a ration card, this thing first come first serve basis. No, here it depends on the severity of injury we go about. So that's called the prioritizing. That process is called triage. What is that? Triage. Okay, very very important terminology. We all should understand and remember this triage. Okay, triage literally meaning is to sort out, to sort. Okay, very good Simran. Okay, correct, it is triage. So what we do is we see all the patients. Okay, we just overlook all the patients and we give them some tags. Okay, we give them tags are available, hand tags or some paper slips. We allot it to them just quickly, within a minute we can allot to all the 30 patients there. Okay, that's called tagging the patients. So there are 4 types of tags. What are those? One is red tag, one is yellow tag, one is green tag, and one is black tag. What is red tag? Red tag is the patients who are having immediate life-threatening injuries. Immediately, within seconds or minutes, they lose their life. That is a condition. Immediately life-threatening injuries, and which requires immediate resuscitation and intervention, both. Hope it's clear now. They are called red tag categories of the patient, so that you will in the beginning only you can make out who are having this immediate life-threatening injuries. I'll tell what are those, then you give it to them. Then the second line of treatment goes to the yellow tag category. What is yellow tag is? Yellow tag is not immediately life-threatening or limb-threatening injury. It is also serious, but not immediately, within minutes or within seconds. It's not going to kill anyone. Okay, you can take some time, hours, to treat that patient. There also patient require resuscitation intervention, but not immediately. Hope it's clear. Next, coming to the green. What is green means? Walking injured. Yes, he has sustained a fracture. Okay, he has sustained a injury. Okay, but he can mobilize, he can walk, he can talk, everything. Such patients are called green. Then there is something called black. Okay, there is a black label. In black label, already dead or moribund or pulseless patients are labeled as moribund, black label. Okay, so these are the 4 tags you give to the patient. Then how to go about is, the approach is called, easily you can remember the mnemonic SALT. What is SALT? When an multiple injured patient comes, you have to do SALT. What is SALT? First you have to sort out this the tagging I told. Then you assess one by one patients, you assess, and you have to start delivering the life-saving treatment. Okay, life-saving treatment means it is resuscitation. At least primary aid, the first aid you have to give in that wherever the patient is there, in a primary health center, CHC or wherever it is. Then for the definitive treatment, you have to transfer them to a higher center where all the equipments, all the facilities, all the specialists are available. There you have to transfer them for the definitive treatment. While transferring also, when you transfer the patient from a peripheral center to a higher center, there is a protocol is there. It's not just you put them in an ambulance and send them on the way, something happens and they are no more when they reach the destination. It should not happen, no. So what we follow is, it's called MIST protocol. What is that? It's called MIST protocol. What is MIST? What is MIST is? MIST protocol. Okay, MIST protocol. First, as soon as you take the patient to that center, higher center, you should be able to tell the doctor in charge there what is the mechanism of injury. It's an accidental injury, he fell down from height, or it's a burn injury. What are the mechanism of injury? Then where all injury sustained, where all does he is having a spine injury, he's having a maxillofacial injury, he's having a left eye injured. Okay, so what are the injuries sustained, you should be able to tell to the in charge there. And what are the signs and symptoms with which he presented to you, whether he had any airway compromise, whether he had any breathing issues, whether he had any tachycardia, all those things, signs and symptoms, you should be able to tell the in charge there. Fourth thing is, what is the treatment already given and how he was transported till there. This is called MIST protocol. Mechanism of injury, injury sustained, and signs and symptoms, and the treatment or transport facilities provided. This is called MIST. Okay, hope it's clear so far. You are all able to follow? Okay, follow me. The speed is okay? Fine. So remember why we are doing this, because why we are transporting immediately, or why we are doing this triage, everything, because if you follow protocol, if you do everything, any approach, anything systematically, including your MDS preparation, okay, if you do systematically from the beginning, you can achieve anything. You will be successful. So here also in trauma also, the first R in trauma is considered as golden R. It's considered as golden R. So as soon as he injured, if you do the needful within 1 hour, so the high chances that he will survive. So you can't waste time in trauma patients. So you have to, whatever it is, whatever the needful is there, you have to do at the earliest. So first 1 hour, the high chances is whatever the injury, whatever the mechanism, that patient will survive for a longer. The high chances within 1 hour if you start the intervention. So please don't be well equipped, both mentally as well as physically, with all the facilities, and then whatever required to be done, first aid or primary things, you do it whenever and wherever you are, and then for the definitive thing, you can refer them to a higher center where everything is available. That is called MIST protocol, salting, Now, how do we treat a trauma patient? What do we follow in India? There are so many guidelines are there throughout the world. Different parts follow different guidelines. In India, we use what is called ATLS protocol. Anyone, what is ATLS? Please, you all have undergone this training, maybe most of you. Can you please tell me what is ATLS protocol? Please, Simran. Akshita, I am very happy to see so many active participations in the chats. Can anyone say what is ATLS? Advanced anyone? Advanced trauma life support. Okay, so it's a all the guidelines are given by the American Society of Trauma. Okay, very good. Advanced trauma life support. Dr. Himani, very good. Very good, Kushi. Very good, Bidhi. Very excellent answer. Most of you know all those things, but still I want to reinforce the things and get it registered in your mind. Okay. So here in ATLS protocol, as per the ATLS protocol, there is something called primary survey and secondary survey. Okay. Now you, by the word itself, it's self-explanatory. What is primary survey? First, preliminary, as a preliminary, quick assessment is called primary survey. You quickly get to see or get to examine whatever the patient having. That's called primary survey. And then detailed. Okay, this is called quick examination. Quick examination to rule out anything life threatening. It's called primary survey. Then secondary is detailed examination. Detailed head to toe examination is secondary survey. Hope it's clear. Okay, primary and secondary. So in primary, what all to check for, which is immediately killing or which can cause any kind of permanent damage to the patient, that you have to look into, right? So you again there is a criteria for that. That is ABCDE. You have to go in this order only and only. Okay, no alternatives or no shortcuts. ABCDE. What is A? A refers to airway. Please note down, each and every word is important, their order is important, and the wording is also important. Okay, you can't, it's not simple English or grammar thing here. Each and everything is protocolized, and so you have to follow the same words here. So what is ABCD is A for airway and airway with restriction of cervical spine movement. Just restriction, note it here. What is B is breathing. Okay, breathing, it includes both ventilation, that is, and oxygenation, whether he is getting enough oxygen or not. C for circulation with hemorrhage control. Okay, circulation, what are blood circulation, whether it's maintained or not, and the entire body is getting enough blood or not. Okay, and if there are any bleeding, how to control that. That is C. D for any disability. Disability, we are referring to the neurological deficits. Okay, any nerve injuries are there that is causing any restriction of movements or anything. Neurological deficits are there not. E for exposure. Okay, it's called we can control him if it is completely exposed and clothing everything gone. You have to warm him up. Otherwise, hypothermia will lead to death. Okay, so like that. Exposure also very important. So this is ABCDE as per the ATLS protocol included in the primary survey. Hope it's clear what all the components of ABCDE or primary survey. Then we'll go do a detailed or elaborate head to toe examination in the secondary survey. Okay, now we'll see important thing. Can you please Drishtija, there is something called CABCD also, but it's not a part of that is called NICE guidelines. Okay, that is different, which UK follows that. UK follows this CABCD. It's not a ATLS protocol. You are right. I told you, there are so many types of protocols are there. C for control of bleeding, and some people say that is also C-spine stabilization also. But in ATLS, this is the ABCDE is the protocol. Okay, there are so many other approaches like that. What you told is, don't get confused. In India, in trauma, we follow ABCDE protocol as per ATLS. Hope it's clear. People may teach you differently, or in different books it might have given differently because they refer different other sources. CABCD as per the NICE guidelines, it's all given in our Bailey book and all, because they follow UK guidelines. This is what we follow in India's American guidelines. Okay, so hope it's clear. Whatever it is, I'll tell you in your entrance exam what the type of question asked and how to go about that. Definitely, just know the basics first, and then the definite questions. What most probably asked, that also I'll be discussing with you, then you will understand better. Okay, whatever may be the question, whatever may be the protocols we are learning, but ultimately the answer is only one. I'll make you so confident about even the questions also at the end of the discussion. Hope it's clear now. Drishti, are you okay with that, the explanation? Okay, fine. So please write down or please note along with me what are the immediately, as any medical or dental professional, you should know what is immediately life threatening conditions. Even in sleep, if I ask, you should be able to tell this 6 condition. One is any kind of airway obstruction. Immediately, see for yourself. If there is bleeding from your hand, like torrential bleeding is there, even then it can last for a few minutes or some 1 hour, because you have some 4.5 to 5 liters of blood. It won't get exsanguinated so easily or so soon. But imagine closing your mouth and nose for just 30 seconds. Is it possible really? Even 30 seconds you can't hold your breath or mouth closed. So which is more important? It's not the bleeding, it's airway. If its airway is obstructed even for 30 seconds, you say, or 1 minute, there is a high chance that patient may die. So that's the first priority. So airway, any airway obstruction is there, patient may die immediately. So you have to give it a priority. Second thing is any tracheobronchial injury. Whatever the air you take in, it goes through via the trachea, right? So it's again a airway obstruction only. So any kind of neck injuries leading to tracheobronchial injury, that should be the taking care of it is the first priority. So these two belongs to airway, correct? Airway A. Then coming to tension pneumothorax. Tension, not our routine tension, the usual tension. Tension refers to the inside the lung, thoracic cavity. There is, because of some air entry, there is lot of tension because lot of pressure is there. Pneumo means air inside the thorax, inside the pleura. The lungs is there. Okay, I will discuss that. That is the most important thing in the tension pneumothorax actually in the entire trauma. So we'll discuss in detail what is tension pneumothorax, how to do about. So just know for now, tension pneumothorax and open pneumothorax, in which breathing is not happening properly. So this is also very emergency and you needs very dire interventions. Breathing. Then there is massive hemothorax. Hemo means blood. In thorax, the entire thorax is filled with blood. So that's also dire emergency. And cardiac tamponade. Heart is beating like this because of some external compression. Heart is not able to beat. The outside which fully blood filled because of trauma. So heart is not able to beat. Then what will happen? The entire body will not get blood. So patient, we will die immediately. So these two belongs to circulation category. Correct? So that is ABC. In each we have two conditions: airway obstruction and tracheobronchial injury pertaining to airway problems, and tension pneumothorax and open pneumothorax, which belongs to breathing category, and massive hemothorax and cardiac tamponade, which belongs to circulatory category. So these are the 6 immediately life threatening. This I have not decided this, okay, which these are all given by the guidelines. As per the guidelines, they say these 6 are the most immediately life threatening. So know it very well, because you don't have time to call your friends, or you can't call your general surgery friends or anyone who, when you are in trauma bay, okay, in your emergency room, all are posted together. Your maxillofacial surgeon will be resident, will be there, general surgery resident, OBG resident, all will be there. Most of them would have gone for a cup of coffee or tea. You alone sitting there, okay. Then a patient comes with tension pneumothorax. You can't tell him, please wait, my general surgery friend has gone there for coffee break, he will come in another 20 minutes, then he will see. No, you don't have that luxury in our field. So okay, so as even dental graduate also, you should be able to manage this. That's why we are learning even general medicine, general surgery also in our curriculum, right? So okay, now imagine yourself to be a ATLS expert who can handle the trauma, and how to go about. You imagine yourself to be in a situation where there is a trauma has happened. You are going there to help them. So how to help? Okay, how to help them? First and foremost thing in any, this is a question also many times asked. What the first step you will do? There is a accident has happened there. 2 people are lying on the road. What's the first thing you will do? It's not the bleeding control. It's not the CPR as you see in the movies. No, The first step in any trauma resuscitation is scene. First step, always remember, first step is scene safety. If you are alive, if you are good, only then you can make others better, right? Okay, patient is lying on the road and you start the CPR, then and there itself another bus will come and hit you both. Okay, so that should not be the case. First you bring him out of the road and in a very safe area, you make him lie down on a very hard surface, then you do whatever you want. So scene safety. And patient is drowning, okay, you can't go there into the sea and you start doing CPR or resuscitating him there only. No, you have to bring him out of the sea or waters and put him on the floor, and then only you can do the resuscitation. Your patient is caught a electric wire and he is having electrocution, okay, and you also go and catch him and pull him away. No, you can't do that, because you will also get electrocuted. So what you have to do is, you have to give him a wooden log or wooden roll and bring him out of the electric wire, and then in a safe area, then only you can start the resuscitation. So scene safety, clearing even the people around. Some 10 people mob will be surrounding and taking the selfies in that accident area. You have seen all those things. Nowadays nobody helps. Instead everyone interested in making a reel and posting in social media. So only you are there to help there. So first thing is, go clear the place, clear all the mob, everything, then only you can do. Otherwise when you are doing CPR, people will follow on you, both of you will get your ribs broken. Scene safety, because it's very important, first step, and many times ask questions, so I am stressing so much. Second things, check for response. As you go to the patient, call, knock him. Hello, are you there? Can you please talk something? You knock him. Check for his response. And if he's not responding, okay, immediately, what is the next step? Again, last time asked entrance exam question, it is last times, call for help. Anything, because if it's a heart attack, he might have fallen due to heart attack, or it might be due to trauma, anything. Again, what you, as a resuscitator, what is the first thing what you're going to do is call for help, because anything you can't do alone, right? You need help, or you need some equipments to give some shock or defibrillate or do some CPR also. You need 2 people. You can't continuously do for till the ambulance arrive, right? So you have to call for help. Immediately you ask your friend or whoever bystander there, call the ambulance and tell them to come immediately to this place. Here there is a patient who's fallen down. You bring the defibrillator, and come to this area as soon as possible. This should be your direction also when you call for help. Okay. After that, talk to the patient, right? Conversing with the patient. Now when you try to talk, patient he may either talk or may not talk, right? 2 scenarios, 2 possibilities. If the patient is talking, then fine. When you are able to talk, see, some peanut is gone into your trachea, able to talk? No. When there is obstruction, you can't talk. So patient is talking means there is no airway is compromised, airway is not obstructed. So then you can just there is some breathing issues are there, so you can just use some oxygen mask if it's available, okay, or then you put immediately airway. After this thing, you give the collar, because you don't know what is the mechanism of injury, and or he's just fallen. When moving him here and there, he may have suffered some cervical injury, spine injury. Spine injury is deadly. Okay, you will not come to know also. Patient also can't tell that this is having injury here. So when you lifting his head and moving from one place to another, he may further injure his spine, and patient may have permanent irreversible neurological deficits. So immediately put a collar. What you do is immediately put a cervical collar. What type of collar, and I'll tell you in detail later. So immediately put a collar and then go for B. So airway you have assessed and done the needful to secure the airway, maintain the airway. Then only you have gone, and along with that you have done the restriction of the C-spine movement. Along with the airway, what I told you was the second part is restriction of the cervical spine movement. For that you have put a cervical collar. Then you are going to the second, what is that? B. That is breathing. Only like that. So after not just checking, there is a problem, you have to intervene also immediately. Hope it's clear now. If he's not talking, the patient is not talking, what are the features says that he's not talking or he's not able to talk? Patient is having tachypnea. That is the earliest feature. That's the most consistent feature is tachypnea. Patient having shortness of breath because something struck. His airway is blocked and he's not able to take air properly. He's breathing with difficulty, tachypnea. Okay, use of accessory muscles of respiration, sternocleidomastoid and intercostal muscles that is using to breathe. Okay, that is, and snoring because of some obstruction in the airway, there is snoring, gurgling, hoarseness of voice is there, or some stridor. That is stridor. Okay, stridor, that kind of voices are coming out, and as a late sign, if it's already late, patient may already develop, because oxygen is not entering into the body, or the blood is not getting enough oxygen, so patient may develop cyanosis. It's a late sign. Initially body tries to compensate in some or the other way. If it's not happening, then gone patient, then cyanosis sets in, then patient may go into the failure, and immediately he may succumb. So what you do next when your patient is having such features, then you suspect some airway problem is suspect, then immediately you suspect it, not just suspecting, you have to intervene also. How do you intervene is by securing the airway. First thing, how do you secure your airway is by you check for any, open the mouth, oral cavity, and check if there are any foreign body, if there are any clot, or if there are any secretions which is blocking the airway. So most of the time, the common thing to block the airway is tongue fall, tongue bite or tongue fall. Tongue has fallen back when he's become unconscious or so. So put your finger and try to remove that any foreign bodies, any secretions, any tongue, anything is there, just try to pull it out. So most of them get recovered the blocked airway with that only. Even after swiping the hand, fingers, even this persists, that what are the airway obstruction features. Then second thing what you do is immediately, I told you airway, first thing is trying to secure it. Along with that, you have to cervical spine protection. Collar you have to put anyway, in either way. If its patient is talking or not, you have to put that. As soon as you found that he is having some airway issues, after finding out, before doing anything definitive, you have to put a cervical collar, because while doing the maneuvers for the securing airway, you may injure the spine again. So first, always, this is a common sense, right? I know I am telling you that airway and spine are equally dangerous. So before airway, you are doing anything intervention to the airway, just secure the, because since both are equally, one is 51%, one is 49%. Okay, airway is 51 and cervical spine is 49. So you secure them, protect them first, then do the interventions for the airway. Okay, so how do you maintain the airway? Even after taking out the foreign body, everything, even then patient is having respiratory difficulty, then what you do is, there are two maneuvers with which you can secure the airway or maintain the airway. That is called head tilt and jaw thrust. Please write down along with me, is very important. Head tilt and jaw thrust maneuvers. Okay, what is head tilt is, see, like this, hold one hand over the forehead and one way over the chin, and okay, and tilt, make the chin upwards like this. So that time the airway becomes straight, and whatever some kinking or block is there, it may get relieved. It's called head tilt, and then it's called jaw thrust. Give a gentle thrust to the, see, as shown in the image, give jaw thrust to the patient. So whatever the, if there is any block, obstruction to the airway, that may get cleared. Okay, so this has to be done with the what is it called, Mills is called manual inline stabilization. One has to be holding his head or the spine in position, because whenever whatever you do, jaw thrust and all, your spine should not get injured. So one person will be holding the head in position, so that it won't shake or bend when you are doing all these maneuvers. It's called manually inline the spine with the head, inline stabilization. One will be doing that, another one will be doing the chin lift or the jaw thrust, whatever the maneuvers are there too. Once the airways become patent, then you give oxygen mask. When you give the oxygen mask, so that his breathing is comfortable. Okay, then after that, you have done the cervical spine protection now till the collar has arrived. Now the collar has come, you can put a semi-rigid. This is again important, not the common collars what we see. Some people have this spondylosis, so they use some rigid collars or some soft collars while riding and all. This is not that. Okay, this is special type of collar available. It's called semi-rigid cervical collar. Name of it, which is Philadelphia collar. Philadelphia, you know the Philadelphia place. This is called Philadelphia collar. See, it will be like this. Along with the collar, there will be a hole in this. See, if you want to later put tracheostomy or anything, with that only you can do. You will not have to remove that. So this is a Philadelphia collar, semi-rigid, along with the opening in the neck. It's called Philadelphia collar. You put that, and now Once your airway is maintaining now, but you can't leave it like that, no, it may again go into collapse. So how do you secure the airway or maintain the airways? Either by definitive airway or adjunct, or permanent airway or temporary airway. Definitive means permanent for that time being. For adjunct is only for temporary, for for the time being you are using that adjunct airway. So when you do definitive airway, what kind of definitive airway use is, already patient is stabilized, so in that only orotracheal intubation or nasotracheal. If the oral facial injury is there, then you can do nasotracheal intubation into the trachea. If anything is going into the trachea, through the vocal cords into the trachea, if anything is going, then it's called definitive airway. It's definitive, into directly going into the airway. Okay, if it's not, if it's only in the oral cavity, it's only above the trachea. If your any adjunct is there, then it's called adjunct airway. Okay, there is something called oropharyngeal. It's going only till the pharynx, it's going, not into the trachea. Oropharyngeal airway, nasopharyngeal airway, mask airway. There are so many varieties are there. We'll see one by one because they are the questions for you. So when you can do this thing adjunct airway is when patient is not having apnea. When not having apnea, or when saturation is less than 85%, or GCS is less than 8 is there. Okay, then you have to do definitive when the patient is having apnea or saturation very low, or patient GCS. I'll tell you what is GCS later. If it's less than or equal to 8, then you have to do definitive. If these features are not there, he's not having any cessation of breathing, or patient saturation is maintained with just the oxygen with more than 85%, on the GCS is more, is maybe patient is conscious or unconscious, semi-conscious, unconscious is less than 8. Okay, so in that scenario you can do adjunct airway in the form of oropharyngeal airway, and now the airway has not got any problem, so you can go to the B, breathing. Okay, this is how you, now that in some people, because you have to do in a very limited space and within some instruments, sometimes this orotracheal intubation may not be possible. You know, you have seen in the OTs, you have attended some maxillofacial surgery cases and all in your during internship. You have seen how difficult it is to put a endotracheal tube. So sometimes this may not be possible in a trauma scenario. Then what you do is do cricothyroidotomy. Otomy means opening and leaving it like that. Any otomy means, okay. Cricothyroidotomy means you do this is a cricothyroid membrane. You know, na, in the neck there is a the thyroid hyoid bone. Then you have, 1 second. See, that's a hyoid bone is there. Then the thyroid cartilage is there, right? Thyroid cartilage is there. Then below which there is a cricoid bone. So in between thyroid and cricoid bone there is a cricohyoid membrane is there. Cricohyoid membrane. There is you can just make out this is the thyroid cartilage, and the most prominent ring here is the cricoid cartilage. In between that there is a space is there. You just take any needle you take immediately and just put it in that space. It's called needle cricothyroidotomy. It's an emergency procedure. Anyone without any anesthesia, anything, you can able to just insert a needle into this space blindly. Okay, this will secure the airway. You can take the air through that for time being. If your upper airway is blocked, you can connect to a lower airway through needle cricothyroidotomy. Okay, then you can put a tube insert. See, initially through this. Can you see in the how to do cricothyroidotomy? So this is the cricothyroid space here. You make a small nick there in using a blade and directly put the needle also. No, if you are not, these things are not available, this is the definitive way of doing it. Then make a nick and create a space there and put a tube like this. You get a endotracheal tube like this, and you can put it inside the cricothyroid membrane. Okay, and secure it. Then that's how you can umbo bag. You can connect here, or oxygen supply. You can connect here, which will directly go into the lungs. Okay, that's called cricothyroidotomy. Okay, hope it's clear now. So ultimately the summary of airway is, how much are you, if you, I don't know how much you're clear with or understood. So I think Aparajita, I have already told about chin lift and jaw thrust. I think that was the, any doubt? Yes, Shilpa, you are right, above the carina it's called. Okay, correct. And okay, now these are the questions related to you are only two. One thing is airway is the first, airway assessment is the first thing, then you do cervical spine restriction, then you do maintenance of airway, right? That's what you saw. First you understood that there is a problem with the airway, then before doing a cricothyroidom or anything definitive treatment for that, what you did was stabilization of the cervical spine. So this is the priority. First airway assessment, then protection of the cervical spine, then definitive treatment for the airway. So this, any question, they'll try to confuse you in many ways. They'll give some very big problems, heavily bleeding patient and is unconscious, this, that and all they'll give. Even then the protocol remains the same. First thing is airway assessment, cervical spine. So make this one line clearly registered in your mind. Whatever type of questions they ask, you can answer with this. Most of them belong to airway only. Your answers also will be always airway only. Most of the time in your exam you see anything in any option there is airway, that is a correct answer most of the times. Okay. So, and at the end of the trauma discussion, you will be in a position to deal with any kind of trauma questions. That's different. Anyway, I am telling you a hint also, giving a clue about your question, possible questions, and even the answer also for that. That is, most of the time they ask questions related to airway. Okay, so be prepared. And what the questions they ask as image based question they can ask pertaining to this particular topic. So many you also have seen there are so many instruments, and you also come across see so many endotracheal tube, this tube, that tube. So they can be kept as an image and ask you what is this. So we heard that there are two types of airway, definitive and adjunct airway. For definitive airway we use endotracheal intubation. It can be either oral intubation, orally, or through nasally you can intubate, or you can do surgically. Tracheostomy you can do, or just like I showed now, cricothyroidotomy you can do. These are the other ways of securing the airway surgically. This is a definitive one. You can keep it like that for long duration. So this is how the endotracheal tube is seen. Okay, in your this put through the nose you can put, or through oral also, oral or nasal endotracheal. It goes through the trachea. Okay, through the trachea it goes. So it's called endotracheal tube. Just this is a inflatable balloon to keep it there only. Otherwise a patient may pull out the tube, no, if it's irritable or if it's not very fully conscious, so he can take out. So to make it self the sustaining there. Okay, so inflatable balloons are used, and different sizes are there. What is this? Anyone? What is this? You all seen this? Yes, Nami. So many IBQs are given in your exam. So what are the possible things? I am just letting you know. So please be prepared. Have an orientation like that when you read. So these are the possible. Along with this question, this can be asked as an image also. So I should be knowing how it looks like. What is this? Anyone can tell? What is this tube? It's smaller than the endotracheal tube. So and it's used as a definitive airway only. So can you please tell me what it is? Yes, very good. Not exactly, Shilpa. This is a tracheostomy tube. Okay, tracheostomy tube again with the inflatable balloon. Okay, this is a tracheostomy. Through the trachea, you directly into the second space. Tracheal space you directly insert into the tracheostomy tube. Okay, then what are adjunct airways? Adjunct you have one is oropharyngeal, into the only to the till the pharynx, from the oral cavity till the pharynx only, oropharyngeal or nasopharyngeal airway, or you have laryngeal mask airway, or then is something called multiluminal esophageal tube is there. So this is your oropharyngeal tube. See, just till the pharynx only it is present, just for a adjunct, as a for a time being this is used. Second thing is this is, what is this? This LMA mask, laryngeal mask airway. See, this has got a, in the larynx this holds there in the place. This covers the entire laryngeal inlet. So laryngeal airway, laryngeal mask airway it's called. Okay, LMA. And this is, see, as you can see in the tip here, it's called multiple inlets. Correct? 1, 2, 3, 4. Okay, and it goes into the esophagus and kept there. Okay, so this is called multiluminal esophageal tube. So these are the different types of adjunct airways. So for you the question is, mostly they can ask you, in a maxillofacial trauma, when the entire face is shattered, correct? Nasal bone fracture will be there, it will be bleeding, and the palate is fractured, maxillary bone, zygomatic arch is gone, and entire its tongue is lacerated, there is a lot of bleeding from there. Mandible also there may be fracture, you don't know. So orbital, medial orbital fracture is there. So when the shattered face is there, then what you can do? You can't put any of this airway, right? You can't put anything orally, you can't put anything nasally. Then what you will do? In such case, the answer becomes needle. So in the neck, you can't do anything in the face, something in the neck you can do. Just now we saw there is needle cricothyroidotomy in the beginning, just a needle, insert a needle and secure the airway. Then then the time is available, you can do definitive surgical cricothyroidotomy. Put a tube and keep it there. Hope it's clear. This is most common type of questions asked. As the scenario changes, you can logically answer. When this entire thing is shattered, you can't try to negotiate a tube through that broken bones, right? Then another way of, we know how to secure airway through the neck. Hope it's clear. Next, coming to once the airway is done, then we go to the breathing. Okay, please, if possible, from this one chart, one question will be definitely there in your exam. Definite means definitely one question will be there from this box. So how many times you read this, how much you understand this will be useful for your entrance exam, but also for your clinical practice also. Okay, how to differentiate between two conditions, that is pneumothorax and hemothorax. I'll just let you know here what are the different parameters you have to look at and how to assess them. Breathing, I told you what are the breathing difficulty, mainly pneumothorax. If there is a pneumothorax is there, then there will be breathing difficulty. Along with that, hemothorax also there, that can collapse the lung and can create breathing issues, right? So there is something called simple pneumothorax. Okay, then it's called tension pneumothorax. Then there is something called open pneumothorax. There are three varieties of pneumothorax. Pneumothorax means, see, there is a lungs. I just show you here. It's a lungs, right? Both the sides there is a trachea. Okay, there is coming, see, lungs. Lung is covered by a protective layer called, what is this? Anyone? Can anybody say what is that? Lungs is covered by what? Is that rib? Lung is covered by which layer? Please answer. You have become again. Is it so boring? The class? Am I very slow? Pleura. Very good, Nami. Now some become active. Okay, it's covered by pleura. Pleura again got two layers: parietal pleura and visceral pleura. So just imagine like that. There is one space in between the lungs and the body, that is pleura. So normally inside lungs, what is there? Air is there, correct? Inside the lung there is air, but outside the lung and within the pleura, that is pleural fluid is there. Pleural fluid, correct? Pleural fluid present in the this space. Sorry, in this space there is pleural fluid is there. Pleural fluid is there like this. So what happens whenever there is an injury, any kind of injury, maybe external injury, from internal injury, anything, any kind of injury, there is a break in the lung parenchyma or in the pleura. For say there is a small break here, small break in the, okay, this small break in the here in the pleura. So there is a injury here. So from outside atmosphere, air can enter in, correct? Air can enter into the pleural space and more air is accumulated there. Or if there is an injury in the lung parenchyma or in the trachea, from here also air can enter into the pleural space, where normally when some little bit of fluid is there, now air is coming and getting accumulated there. So air is getting accumulated like a balloon in the pleural space and lung is getting compressed. Okay, so that is called pneumothorax. If it's lot of air is present and the lung is entirely compressed, then it's called tension pneumothorax. Just like, see, you are put into a corner and fully pushed in a private buses, you have seen, no? In the fully loaded private buses, how it is, like all are just compressed like this. It's called tension pneumothorax. Simple pneumothorax means yes, some air entry is there from outside, but it's not causing any pressure there. That is simple pneumothorax. Open pneumothorax means injury is leading to the outside atmosphere. Outside atmosphere air is coming inside. Then it's called open pneumothorax. I will discuss again after this slide. Just for now, you understand that much. Simple pneumothorax, tension pneumothorax. What is hemothorax is in the same pleural space instead of air if blood is accumulated because of some vessel injury. If blood is accumulating there, if little bit blood, then we call simple hemothorax. And like I said, there's massive collection of blood there, it's called massive hemothorax. So how do they present with? The patient will not come and tell, I'm having pneumothorax, I'm having hemothorax. With subtle signs and symptoms, you should be able to conclude that patient is having, yes, he's having pneumothorax. Clinical you can tell, you need not have to get any investigations done for this. I'll make it so simple for you. Just by looking at him, just auscultating, you can tell that the patient has pneumothorax or hemothorax, or if he's alright. So first thing you look at it, I told you earlier also, what is the early symptom with which patient comes with airway difficulty or breathing difficulties? Tachypnea. Patient is having shallow breathing like this. His respiratory rate would have been increased. Normally it is 14 to 16. If it's more than 20, say 20 to 24 is respiratory rate, then he's having tachypnea. In tension pneumothorax, it will be much higher, maybe more than 30 and all. Even massive hemothorax also will be more than 30. Whereas in simple hemothorax, it will be slightly elevated. So I just you understood the severity, right? He's having severe tachypnea means the inside the pressure is also high. Patient is having slightly breathing highly means the problem is also not that severe. You understand that. Second thing is blood pressure. Blood pressure in normal, like in pneumothorax or simple hemothorax, it remains normal. Only little bit of bleeding is there, or little bit of lung is compressed, then it's okay. Blood pressure is somehow maintained by the body. When there is a tension pneumothorax, entire right lung or the left lung is fully compressed, is not taking part in ventilation, then there is no venous output. You know, na? All the blood from the heart, it comes to the lungs, there get mixed with the oxygen and again supplied back to the heart and comes out to the entire body. So if the lung is not participating, that means what? The lung blood is not going out to the body. So patient will have hypotension. The body will not get enough blood to supply. So they'll have hypotension. Same thing happens in massive hemothorax. Most of the blood is collected there. It's not getting circulated. So circulatory blood volume is decreased. So they will have hypotension. Whereas simple hemothorax, where some 200-300 ml blood is lost, then it will not cause any hypotension. What is JVP? Jugular venous pressure. You know, there is a vein, big vein, which drains all the head and neck. It's called jugular vein. Correct? Jugular venous pressure. We look at the jugular venous pressure because something is pressed here, compressed here means the veins will get dilated, right? There is obstruction. Distally means the proximal thing gets swollen up. Then your class door is blocked. Means all of you get accumulated in the class only, and it becomes a big it's like a very close space. So many people are accumulated. You understand? It's like a very difficult situation. So if the door is open, you can keep going out and coming in. So then it's free to move in and out. Otherwise, if you're closed in one place, similarly, because of enlargement of pleura, if it's compressing the vein coming into the heart, jugular vein, so vein gets dilated. Then the pressure also becomes high. Jugular venous pressure we see. In simple pneumothorax, it will be normal only. In case of tension pneumothorax, it will be elevated. The jugular venous pressure, because pleura is compressing over the vein, so vein is not able to drain the blood. It's getting accumulated there, so pressure increases. Massive hemothorax, it decreases because blood volume is less, means pressure also less. In simple hemothorax, no, Nami. In bodybuilders, we can see their veins. No, that is not GAVP. In bodybuilders, why we can see the veins? Because their fat tissue is less. They are very muscular. So vein is present between the fat and the muscle, right? So their fat is less, muscle is more. So they are pushing the vein towards the subcutaneous area. Just below the skin, there will be no, instead of fat, there will be veins. That's why there will be more prominent veins will be seen. That is not JVP. JVP is jugular vein. Normally you can't see here. In case of compression and all, or because of some heart failure, so many reasons are there, it will be prominently seen, and you can make out the vein prominently. It's called JVP, jugular venous pressure. Then on percussion, you have done no percussion, you learned, okay, basics of percussions, you learned. When you percuss like this over the chest wall, if air is there, completely air filled, it will be hyper resonant. Resonant means like hollow. When you this thing percuss like this, or put your fingers over that and press or hit like this, it will be hyper resonant note will be there. Even both when the air is there, it will be fully hollow, so you will get resonant note. If there is a hemothorax, means some fluid is collected there, then it will be dull note. Over water, if you hit like this, it will be dull note, or even the solid also same. And simple hemothorax, it will be almost normal, because little bit of blood is there. The usually the resonant, like what to say, your percussion note will be dull. Then coming to the breath sounds, what will happen if the half of the lungs is collapsed? Okay, only with the heart, only half lungs patient is breathing on the one side. Then the breath sounds will be either decreased, or when the entire lung is collapsed, it may become absent also. Whereas in tension pneumothorax, already the entire lung is compressed. I told you, it's not able to expand. So can you, without expanding and movement of the lungs, can you hear the breath sound? Is it possible? No. Only with the movement of the lungs, inspiration and expiration, you can hear the sounds, right? So that's not happening because of the outside compression. The entire lung is compressed like this. So can you hear the lung breath sounds? No, not possible. So tension pneumothorax, the classical sign what you get is, one is on percussion. What will be there on percussion? You will have hyper resonant note. Second thing, breathless, breath sounds will be absent. This is classical of tension pneumothorax. And if there is a air still pent up or building inside, then it will push the midline, trachea, everything to the opposite side, because air is accumulating and continuously accumulating inside. There is no space to go, so it will push the central structures are there, like trachea and all midline structures, that will be pushed to the opposite side. Okay, so in other things it will not feature immediately. If you get a chest x-ray in simple pneumothorax, you have time to investigate and all, get a chest x-ray, it will show a presence of air inside the pleura. In tension pneumothorax, you don't have time, because I mentioned you, simple pneumothorax was not present in our list, correct? Was it there? Immediately life threatening. Simple pneumothorax not there. Only we have tension pneumothorax and open pneumothorax. Those are the immediately life threatening, and massive hemothorax only, not the simple hemothorax. So in the conditions where you have time, the patient can survive for some time, you can get investigations done and then do the definitive. You can get a chest x-ray, confirm where exactly the pneumothorax or hemothorax is there. Then you can get the treatment. In tension pneumothorax or massive hemothorax, which is immediately life threatening, you don't have time to send him to the x-ray or get a x-ray film done. No, immediately you have to intervene. What's the intervention is? Needle thoracostomy. I told you, just like needle cricothyroidotomy, here also take a wide bore needle and put it in the I tell you where to put, in the fifth intercostal space. You just insert, and all the air will come out. Patient will gives huge sigh. He will relieved. All the air will be vented out, so he will be relieved out of that inside pressure. In massive hemothorax, what you can do is put a chest tube, wide tube. You can put it directly into the pleura, so all the blood whatever is collected will come drained out, so the pressure is relieved. That's the treatment for immediate. It's not definitive treatment, but immediate treatment for tension pneumothorax. If they ask, or the immediate treatment of choice for tension pneumothorax is needle thoracostomy. Needle, very, 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 very important. I can give you 5 out of 5 stars. And second, what you can do for hemothorax and as a definitive procedure for tension pneumothorax is chest tube drainage or chest tube thoracostomy. Very important from your exam point of view and clinical practice also, and most possible question also from trauma. See, this is so you can easily understand what is pneumothorax, what is open pneumothorax, what is tension pneumothorax. You just observe the photo, it's self-explanatory. See, this is the lungs, correct? Please look here. See, this is the normal lungs. Normal lungs is there. It's covered by a very thin rim of pleura. Here what has happened? The air is accumulating from the injury from the trachea or from outside somewhere. Usually in closed pneumothorax from inside only, not from outside. Due to some tracheal rupture, all the air is from the trachea is leaking into the pleural cavity. So air is getting accumulated here in the pleural cavity and compressing the lung tissue. Lung tissue is compressing. Okay, so see, lung is compressed. So this is not taking part in breathing. Only one lung has to ventilate. Okay, that's why the problem. Okay, second, in open pneumothorax there is a rib injury, rib fracture is there, and also pleura also got injured. So outside atmospheric pressure, because high pressure here, low pressure here, so all the air comes inside like this and gets accumulated here. If it persists like that, if you don't intervene in the early stages, it will swell up like this. The air will swell up in the entire thorax and it can lead to tension pneumothorax. See, the trachea, which should be in the midline, it has pushed to the other side. The heart, which should be there in the mid here, it has pushed to the opposite side like that. Midline shift will be there in the tension pneumothorax. Hope this image is clear. Okay, sir, there are some doubts. Nami saying, yes sir, thanks, I understood, very good. Florence is asking, sir, please can you tell us about difference intubations and maxillofacial surgery like orotracheal intubation, submental intubation? Definitely. That is main part of anesthesia. In anesthesia, they will teach you. The anesthesia is a separate class for you. There, they will deal with all kind of intubations. I have another separate class on oral cavity and head and neck also. There, I will be discussing about all the fractures separately. Maxillary fractures, mandibular fractures and all. There, when it comes to the treatment, I will discuss all those things. And Darshana is asking, how do you differentiate between tension pneumothorax and cardiac tamponade? Excellent question, excellent Darshana. I'll come to that. Now, hope with tension pneumothorax is clear now. What is cardiac tamponade? I'll tell in the circulation. Is it okay, Darshan? Hope tension pneumothorax is clear now. So far, Darshana, can you please give me a okay? If not, thumbs down if you're not understood. See, you look at some images, then you will understand better. Some x-rays I have kept for you. See what's happened here. See, can you look at the trachea here? Darshana says, yes sir, okay. So definitive procedure for tension pneumothorax is chest tube drainage. Chest tube is the initially you do needle thoracostomy. Immediately, because chest tube, putting your chest tube and all, it takes time. Till then patient may succumb. So first put a needle and vent out maximum air. Meanwhile, you prepare for all the chest tube and all. Then put a tube. I'll come to that next. There are slides are there on that only. So till you completely understand, I'll not leave you. Why I'm little bit hurrying, because again the same slide, same topic are coming again and again. So I can explain again there also. That's why. See, look at this image. Many times images will be self-explanatory. You will understand better with the images, not with the theoretical explanation. So what's happening here? See, the usually lung shadow should be seen here. Some bronchovascular markings and all. Nimisha, I'll tell. Okay, I'll tell where to put the needle. Everything I'll tell. Ideally, it should be earlier. You know, if you look at your books, still it's given as second intercostal space in the mid-clavicular line. It has to be inserted needle. But now, according to recent update, because that's why that will be a question. Any recent updates will be asked as a question. According to the new ATLS protocol, in adults, there's a clause in adults, it has to be put in the fifth intercostal space in the mid axillary line. In children, it is still the same in the second intercostal space. In children, second intercostal space, mid clavicular line. In adults, it's in the mid axillary line in the fifth intercostal space. Hope it's clear, Nimesha. I'll come to that again. I'll come to that particular part. What's your observation here? See, this is the trachea. Where's the trachea? It should be there. It should have been there here in the midline, right? It has come to the one side like this, trachea, and here entire lung is compressed, not seen only. It's completely compressed, and entirely it's filled with air. Fully black means air. It should be normally, see, lung should be like this. Lung should be, see, lung pulmonary marking and all. You can see the lung border. You can see this is the normal lung. This is how normal lung looks like. See, normally left it should be seen all these bronchovascular markings. Everything you can see here clearly. This is the normal. It should how it looks like. But here, can you see anything? Any bronchovascular markings? Anything? Nothing, because entirely air filled, fully black. Black means air on X-ray. It's a case of tension pneumothorax. Entire left lung is filled with air and it's pushing the mediastinal structure into the opposite side. So tension pneumothorax with mediastinal shift is present. Trachea central shifted to the one side like this. Okay, heart which should have been there here, it's pushed here. See, heart is come till here. So this is tension pneumothorax. What is this? See, this is the normal. Left side is normal here. It should this is how it should be. Here what has happened is, this is the air. Entire thing is air. It is pushing. See, lung is compressed till here. Lung border should have been till here. Now can you see? Lung is only till here. And again the trachea, everything is shifted to the opposite side. So again the tension pneumothorax. What is this? See here the lung marking, everything is normal on the both sides. But if you see in one area, this area okay, looks okay. But if you see here, this small air is black patch is present, correct? Can you make out? Here one black patch. That is simple pneumothorax. Some amount of air is present there. Simple pneumothorax. What is this? Can anybody tell? If it is very black, then is air. Pneumothorax. If anything is white, is liquid. White on X-ray is liquid. Black on X-ray is it's air. So what has happened here? Anyone? Nimesha, Nami, anyone? Can anybody say what has happened in this X-ray? Entire thing has become white, right? Till here it's white. What is this? White. Very good, Santosh. Excellent answer. Excellent, Nami. Excellent. It's hemothorax. It's a blood filled, left sided. The interpretation here is left sided hemothorax. It's massive, right? Almost pleural effusion. Without, if history is not given, you can tell it's a pleural effusion. Darshana, you are right. But when you are dealing in a trauma scenario, most probably that pleural effusion, whatever the effusion, the fluid is, most probably it should be blood. It can't be anything else. So we are directly referring here as hemothorax. It is almost filling up the 80% of the lungs. So it's a massive hemothorax. Massive hemothorax. What is the immediate treatment? Immediate treatment for massive hemothorax is intercostal tube drainage, whereas for tension pneumothorax is just a needle. For to come air, only minimum needle is enough to vent out the air. But for the to bring out the blood, you with a needle it won't come out. You need a bigger tube. That is chest tube drain. I'll show you what is that. Okay, hope it's clear now. See, with the images you can, now you tell now, what is this? Can anybody tell? What is this? See, it's a lung border here. Can you see lung border? Okay, so outside which there is a air is present. So it's a left-sided pneumothorax. Left-sided pneumothorax. There is no mediastinal shaft and all, because trachea is central. Heart is there in the normal position, everything. So only simple pneumothorax. It's a simple pneumothorax. Yes, Nami is telling, sir, is blood due to some fight with someone? Yeah, most probably. Okay, I don't know what exactly cause, but mostly because of fight or fall, something. Okay, some trauma. See here, what is there? There is again pneumothorax. There is no. This is central, trachea central. So it's again a simple pneumothorax. This will be the very good pro boy is telling it's a pneumothorax. Correct answer. So now you understood how to interpret a hemothorax and pneumothorax, and I would say, I would bet on that with any examiner, any surgery paper or surgery questions is incomplete for a UG level or PG level without a question on tension pneumothorax. So there should be a question on this tension pneumothorax. I can bet how much or you want. There will be one question on tension pneumothorax for sure. Any, be it NEET PG, INACT, whatever it is, if he is a good examiner, he should, because it's such a life-threatening condition. Any medical professional should know about this and how to deal with this. It's a must know. So there will be to educate you, at least they should give a question on this. So please be prepared to how to interpret the X-ray of tension pneumothorax or hemothorax. Okay. Hope it's clear. Yes, Nami. Hemothorax is white and pneumothorax is black. Correct. Okay. So where Nami was asking, or someone was asking where to put the needle and all, right? So here you put the needle, or here you put the chest tube. There's something called, remember this one thing, triangle of safety. You see, I'll give a needle and put it into the chest. You're afraid, right? Because all the vital structures are there, heart, lungs, everything. Where to put the needle? If I injure, what if I injure the lung? What if I injure the heart? What if I injure some vessels? It will bleed more. Definitely your afraid. Even I am, as a surgeon, I am afraid to put any needle into the thorax. So they have found a very safe area in our body where whatever you put, it doesn't have any major vessels or any major structures there. That's here underneath your axilla in this area. Okay, this area is called triangle of safety. Triangle of safety is borders. You must know. Anteriorly the what is this muscle? This muscle is called pectoralis major. Your chest muscle is called pectoralis major. So the outer border of the pectoralis major, lateral border of the pectoralis major is the anterior border of the triangle of safety. Whereas on the posterior you have latissimus dorsi muscle, LD. Those who are doing gym and all, they know what is LD. All the muscles they will be knowing very well. LD muscle. Okay, latissimus dorsi muscle forms the posterior wall of the triangle, safety triangle, and the base, the triangle base is formed by the fifth intercostal space, the fifth rib. Okay, so this is a triangle like this, and see, this is how. Can you see? This is the pectoralis major muscle. Okay, it's lateral border of the pectoralis major forms the anterior border of the triangle. Posterior border of the triangle is formed by the latissimus dorsi muscle, and the base of the triangle is formed by the fifth intercostal space. So this is a very safe, under which there is no very vital organs or blood vessels not there. So you can put any needle here, or you can put a tube, anything you can put here safely. That's why it's called triangle of safety. Hope it's clear where to put the needle now. Now you put, see, this is how you put the tube. Where to put the tube, they were asking. Into the fifth intercostal space. Into the fifth intercostal space, they put a chest tube like this, and they will connect it to a water seal drainage. See, this image you should be imprinted in your mind. The tube, not just putting and keeping it open, then the lungs, the negative pressure, whatever there inside the thorax, it will suck the air from outside. So you have to immediately connect it to a water seal. Water seal, see, the tip of the tube should be inserted in the water seal. Then when the air comes out from the chest, there will be water bubble formation here. That's how you can confirm that this is in the correct space. And there will be this water column will be rising. When you take breath, the water column will be rising through this all the time. It just confirms that you have put the tube in the right space. It is into the pleura. It's into the pneumothorax. That's how you can confirm two things. Okay, and where you put exactly? Where you put is inserted in the lower part of the intercostal space. See, these are the this is the sternum. Okay, this is the sternum, and these are the ribs, right? These are the ribs connected here, and you have to put in this is the almost fifth intercostal space. Fifth intercostal space. Where to put in this fifth intercostal space? It should be lower part of the ICS, lower part of the intercostal space, or upper border of the lower rib. For example, if this is the fifth, entire thing is the fifth intercostal space, the two ribs are there, upper rib and lower rib, right? You have to put it upper border of the lower rib. You have to put the tube. See, this is the tube. You have to put in the here, upper border of the lower rib. Why? Because if there is a rib is there, all the vascular bundle or neurovascular bundles is in the here. Here all the neurovascular bundle goes just below the ribs. Just below the rib. See here. If this is a rib, just below the rib, the neurovascular bundles are present. So if you put just below the rib, if you put it can injure the neurovascular bundle. So just above the rib you have to put. Above the rib in the intercostal space, in the lower part of the intercostal space, or just above the rib. If these are the two ribs, if these two are the ribs, you have to put just above this rib, not in this space, not below the rib, but above the rib you have to put. Hope it's clear. Very good, Dr. Libra. She has answered already very well. Already very good. Okay. So Samiksha says she is not able to make out the trachea on the X-ray. Oh, why not? Trachea contains air. Okay. So any air is seen as a black thing. Correct? See. So in this X-ray you can see. So there is and trachea is present usually central. Okay. Can you see? Make out in this some black air dots here. That's a trachea. See in this X-ray, particular X-ray you see. Can you see a black tube like this? Can you see? That is the trachea. See in this very clearly seen. See. This is the trachea. The central, which are the hollow thing where air is there. In this, see, this shifted to, see, air tube is shifted here to the right. Trachea is deviated to the right side. Hope it's clear now, Samiksha. See here, the central, the trachea. Okay, so this is triangle of safety, and where exactly you insert the tube. It's always, please remember, it is inserted in the lower part of the intercostal space or upper border of the rib, any rib, and it's connected to the underwater seal drainage, and with the fogging or air bubbles or water column moving, you can confirm that it is in the right space. Hope it's clear. Okay, then the breathing part is taken care. If you have any breathing issues like tension pneumothorax or open pneumothorax, whatever is there, you can put in chest tube, drain, and take out all the air. Or initially you do needle thoracostomy, and then you do chest tube drainage and take out all the air or blood present, and that's how you take care of the breathing part. Then coming to the circulation. Circulation is most important, and many questions also from circulation only. One is airway is important. From breathing, what's important is tension pneumothorax. Circulation, there is something called hemorrhagic shock. What is shock, my dear friends? Can anybody tell what is shock? Shock means what? Not your exam result shock, not that. What is real shock? Is hypoperfusion, global hypoperfusion. Your body's entire body is not getting enough blood. That's called hypotension, like a shock, hypotensive shock. Okay, that's a shock, means that your the supply demand mismatch. Your body requires 1 liter of blood and it's not getting it. Then it's a condition is called shock. So there is many types of shock are there. The blood is not coming, like going into the different parts of the body because of the hemorrhagic shock. Okay, because there is a lot of bleeding happening, so body is not getting enough blood in the circulation, or cardiogenic shock, or neurogenic shock, or obstructive shock, septic shock. So many types are there. Yes, all of you are right. Okay, all of you are right. Samira, Kriti, Isha, all are right. Inadequate tissue perfusion. Excellent answer. That's the exact word I wanted to know. Sir, please show breathing box slide. What is breathing box slide? I could not. Last portion cannot see. Breathing box slide. Okay. This is the breathing box. Hope you can see now. Hope it's clear now. Okay. Okay. Coming to the circulation. I told so many types of shocks are there. For your exam point of view, what's important is hemorrhagic shock. In hemorrhage, depending on how much blood volume is lost, it can be classified into class 1, class 2, class 3, class 4. At least you know, if not everything in detail, but there is something called class 1 is starting when the minimum blood is lost, say less than 15% of the whole blood volume. If you say you have 5 liters of blood, in that some 600 ml is lost. Okay, it's less than 15%. So then it is called class 1. Class 2 is 15 to 30%. Okay, 500 to 1.5 liters of blood is lost means 750 to 1500 ml is lost means then it's called class 2. Class 3 is 30 to 40% blood lost, then it called class 3. It's called moderate bleeding, hemorrhage, shock, moderate shock, mild shock, moderate shock, and severe shock. Severe shock is more than 40% of the, if you have 5 liters of blood, more than 2 liters is lost, then we call severe shock. What's the initial sign of any shock? Is tachycardia. Body tries to see, one person was doing the job earlier, okay, now pushing something, one person was doing, now his one limb is lost, okay, something is lost, then now 2 people are doing the same work to push that wall or something. So heart compensates for its blood loss by increasing the heart rate. Whatever is it was the blood, it was pushing in 1 beat, now it takes 2 beats to do the same thing. Okay, 2 beats in same time. So heart rate is increased. Tachycardia is the earliest sign of a shock. Okay, so tachycardia, heart rate is normal is 60 to 100. Okay, in early phase of the shock, body tries to somehow compensate for it, and tachycardia will not be there. Whereas in mild shock, the heart rate will be 100 to 120. In moderate, 120 to 140. In severe shock, the heart rate will be more than 140. Okay, So, and blood pressure, the blood pressure is the last to get affected. Initially body tries to compensate in some or the other way. Initially in mild, moderate and even the till the last part of the moderate shock, the blood pressure will be normal. In the last part of moderate shock and severe shock, then they will go into hypotension. Pulse pressure, what happens to the pulse pressure? Difference between the systolic and diastolic pressure is called 120 by 80 we say, no? In that the 40, 120 minus 80, there is a whatever the 40 we get, that is the pulse pressure. Okay, so it will be normal usually in the compensatory phase, and as mild moderate shock sets in, then there will be decreased in the pulse pressure. Respiratory rate also normally, so initially it will be normal, then as I told, there will be tachypnea later on. Urine output is a very good indicator of shock. Urine output will be normal till the mild shock. Once the moderate shock comes in, most of things get affected, most of the parameter gets affected in moderate shock. Mild shock, somehow body tries to compensate. Moderate shock, no. Severe shock, gone. It may go into the irreversible state. What is GCS? We'll see next. Glasgow Coma Scale. The level of consciousness. The body's consciousness is assessed by a scale called Glasgow Coma Scale. It will be normal till the mild shock. Okay, in moderate and severe shock, the conscious level goes down. Patient become more drowsy, maybe semi-conscious, then unconscious later on. Okay, the base deficits. Base deficit means is, you see in our body there is both acid and base is there. Okay, if the acid goes down, base will be deficit and less. Okay, if the base goes down, acid will be deficit, like that. What is initially there is aerobic respiration is going in our body normally because of the oxygen enter body, all the cells metabolized by aerobic metabolism. When the blood is low, blood is getting lost, our body cells are not getting enough blood. No blood means no oxygen. No oxygen means till the metabolism has to occur, no, to survive. So body goes into the mode of anaerobic metabolism. In 12th only we all learnt all those things. Aerobic metabolism, anaerobic. The end product of anaerobic metabolism is lactic acid. So lactic acid is being accumulated after the anaerobic metabolism. More and more lactic acid is accumulated means acidosis happening. This is acidosis. So acid is more, base is coming down. So base deficit. Initially it will be minus 2 the base deficit, then minus 6, then minus 10, and more than minus 10, like that. The more and more base deficits keep happening as the acid level goes up. That's what I mean by, means there is more of anaerobic metabolism happening, which is not good for the body. Need for blood. In the compensatory phase or the mild shock, blood is may not be required because body itself can overcome that deficit. In the moderate, yes, definitely blood requirement is there because more than 30% of the blood is lost, 1/3 of the blood is lost. You have to re-give it in the form of blood itself. In the severe shock, almost 50% blood is lost, means you have to give lot of blood, 2.5 liters you have to give. Means 5-6 units of blood may have to be given, or more than that. It's called massive transfusion. Hope it's clear. Very good, Nami. Everyone answering so well. I think I'm with the very brilliant students today, very interactive. All are answering very well. Not just answering, they're answering brilliantly. Most of them are very right. And what makes me more happy is they not just answering correctly, but answering exactly the words or the terms what I expecting as an examiner or any person. They'll be having something in mind. No, answer means this the answer. So most of you are answering exactly that. So I'm very happy with that. Okay, not able to see. Okay, now you're able to see. Now you're able to see Urushi. Okay, so this is about this one shock. The entire chart on shock is very important. Just know that there are 4 classes of shock. Hemorrhagic shock, in that most of things try to deteriorate after moderate level of shock. That much you remember. Okay, coming to the circulation, how do you manage a patient with circulatory problem is take two wide bore cannulas. Wide bores in the circumference of the needle should be wide, and short length cannulas you take and insert them into the median antecubital vein in the cubital fossa. There is vein available. Usually when you go to a lab and all, they draw vein blood from that only, no? So you also have done that. So from there you put a 2 wide bore. It's very important. Wide bore short length cannula only. Okay, which is wide bore and all we'll see next. That's also important question for you. If not available, because most of them in shock, then their veins will be collapsed. You can't get it so easily. won't be that superficial, so it may not be accessible. So then what you do is, then put it to a bony thing, directly into the bone like this. See, it's called intraosseous cannulation into the like bone marrow, directly into the bone marrow. You're putting the needle is drilled into the bone marrow like this. Okay, so intraosseous cannulation into the proximal part of the tibia. This bone is called tibia. Especially it is done in children where the small veins it's not gettable. You directly put it in the bone marrow. Okay, intraosseous cannulation, just below the knee joint you put it. Okay, these are the needles you use. That also question asked. See, they have shown this image and asked you what is this. These are the intraosseous needles which you can use for IV fluids and all. Okay, see, intraosseous needles you can see clearly now. If that's also not possible, sometimes the drill, these needles may not be available in all the centers, and the driller, everything become difficult. Then what you can do is venous cut down, one of the major veins in the body, big veins like great saphenous vein or anything in the leg. You can just make a surgically, you can open the skin and the fascia, then you can see the vein, make a nick in the vein and directly put the tube, cannula or tube into the big vein like that. See, he's inserting a tube into the vein. Venotomy is called, venous cut down. Venesection all means the same. He's directly inserting that, then we will tie it so all the fluids can directly go into the vein like this. These are the three ways. Wide bore into the vein. If the vein is not gettable, then you do put it in the intraosseous manner. If that's also not possible, then into big veins in the body you can directly do the venous cut down or venesection. It's called also called venesection. Okay, then you start infusing the fluid, because fluid is lost, blood is lost, means you have to recover that, no, what are the lost fluid is there from the body, because circulatory volume should be replenished. So initially you start with the fluids. The question is not the what you do, which fluid is given. Fluid of choice they'll ask you, which is the fluid of choice for resuscitation in a bleeding patient is crystalloids. Which crystalloid is RL, you know all those things, ringer lactate you know, or is what is given is normal saline. These are the two fluids of choice. Which is the best fluid they'll ask. See, fluid of choice means which we commonly give or which is possible to give in almost all situations. That's fluid of choice. Choice is different. Okay, which is the best? Best is the ideal, which may not do all the times. Okay, we always want to be the best doctor only, who is most earning, who is the most famous, everything. But is it possible to happen every time? Most of we end up being average doctors only. So average doctor is the choice, or there is a common thing. Best is the ideal scenario. So in best fluid, if they ask, that becomes the blood. What is the best substitute for blood is blood only. But immediately blood may not be available. The patient is bled 2.5 liters and he has come to the emergency, and immediately blood is available to give him. You will not keep all the blood ready in the emergency room, right? It will be there in the blood bank to do the cross matching and to bring that blood, and it will take 1 hour time. Till then, by then patient may not be surviving. So initially, fluid of choice is you give fluids, and once the cross matching is everything is done, you get the blood, then you can transfuse the blood. So that's the understanding you should have. Fluid of choice is RL or NS, which is a form of crystalloids. The best fluid is blood. In blood also, which is best, they asked question, which is the preferred blood. It's always a cross matched blood. You are O positive means O positive blood has to be given. If you are AB positive, AB is the best. No, there is no reaction which is going to happen then. But many a times to do the cross matching, it will take 1 hour, 45 minutes the minimum to do a proper cross matching. Till then you can't keep patient like that. Okay, then what is the most commonly used is the universal donor, which is the universal donor O blood group. O blood group is the universal donor, right? So in that also O negative, where there are no antibodies are present, antigens antibodies not present, O negative, that is the best and most commonly used also. So you can write O, very good nummy, you can donate to anyone. Okay, you are O positive, you can give blood to anyone, you are a universal donor. Okay, please explain before fluid of choice. Before fluid of choice is, yes, the first step in circulation management is securing the circulatory part. The circulation happens through veins, the blood, so you can take access to the veins through cannulas. See, there are cannulas like this. See, it's different cannulas there, orange, grey, green, pink. This is orange means 14 gray. The smaller the number, bigger the size. Okay, so at least you take gray or green cannula. They are wide bore cannulas. Wide bore means wide circumference. Okay, and they are inserted into the median cubital veins. Then start the IV fluids, RL or NS. If it's not, you are not getting those veins, then put the needle into the proximal part of the tibia, into the bone marrow, and start giving the fluid. If that's also not possible, then put it into the big veins by cutting the skin and subcutaneous tissue. Okay, venesection. Hope it's clear now. For best, okay. Which is the best guide for fluid resuscitation? These are all questions, okay, and repeatedly asked questions also. So I am stressing more and more there. Best fluid is this thing. Most commonly used is O negative. Best guide for fluid resuscitation. How much to fluid to give? Okay, how do you know whether how much is lost? You can't calculate, right? Is blood in the road 2 liters or 2.5 liters? How do you know really whether how much fluid you have to give? That is measured on the basis of one criteria: urine output. His urine output gives us an idea whether he is having enough adequate fluid in the body or not. Urine output. Normally we have to urinate minimum how much? 0.5. This is very, very important understanding. ml per kg per hour. Means if I am a 60 kg person, I have to pass 30 ml per hour. 30 ml per hour minimum. Okay. If for a pediatric it's 1 ml per kg per hour. If a 10 kg baby is there, baby has to pass minimum 10 ml per hour. Minimum. That is the minimum. With the babies or adult, that patient is passing minimum 0.5 ml per kg per hour, means he is having enough fluid in the body. Your fluid resuscitation is adequate. If the fluid output is less, only 10 ml, that means you are not giving enough fluids. You have to increase the fluid volume. That's the best guide for fluid resuscitation. Requirement of fluid, whether the patient requires or not, initially he requires or not, is best assessed by what something called pulmonary capillary wedge pressure. What is that? And no need to do detail. In medicine anyway, they may teach you pulmonary capillary wedge pressure. Okay, or sometimes this is very difficult to measure, but the best means, but what's commonly done is CVP. CVP, you know, central venous pressure. There are some central veins like jugular vein and all. There you put a catheter and measure the pressure. If it's normal, then no need of fluids. If it's low or high, then you need to modify the fluid resuscitation accordingly. Okay, CVP is says whether the fluid is required or not, whereas you are giving adequately or not fluids. That is assessed by urine output. Hope it's clear. Initially what you do, you secure a wide bore cannulas, okay, 2 cannulas, and you immediately, whatever may be the situation, you give 1 liter of ringer lactate or NS. Stat means flow, continuous, not just in one go. You give 1 liter of normal saline at first. Okay, after that by that time it will be 1 hour. By the time cross match blood will come, then you start giving the blood. How you give the blood is for every 1 pint of PRBC, okay, that is plasma RBCs, you have to concomitantly give 1 FFP and 1 platelets. 1:1:1, not just giving PRBC or just giving FFP. No, we have a protocol for that also. 1:1:1. Okay, PRBC is to FFP is to platelet is 1:1:1. Along with that, if the patient is come within 3 hours of injury, then there is a role of giving a antifibrinolytic, means anti-clotting this thing. Okay, which prevents the continuous bleeding, which helps in clot formation. That's called antifibrinolytic agent. Is injection tranexamic acid. This helps in stopping the bleeding. Injection tranexamic acid, but this shows good role only when the patient present within 3 hours. After that, even the patient have blood enough, then no role of giving this injection tranexamic acid. And this is important in the ratio of 1:1:1. That's important for you to know. Okay, so nowadays you should understand one concept, what is called nowadays when the patient comes with hypotension, right? The bleeding patient, any patient we saw, they come with BP will be low. Nowadays, like earlier, we don't, in any bleeding patient, we don't try to achieve his normal blood pressure. For say his normal blood pressure is 120/80, right? by giving these fluids, blood, whatever it is, we don't aim or we don't try to achieve the normal blood pressure of 120. We want to achieve a blood pressure which is required or which is enough to maintain the body circulation or blood flow into the vital organs. Let's say maybe 90 millimeters is enough. 90 mm of Hg is enough. So we want to maintain only that much. If the pressure is higher than that, what happens? If the pressure is high, bleeding also more. You're right. So if when 90 is enough for me, if one sandwich is enough for me, okay, it fills my stomach. Oh, very tasty. I will eat 2 more. What will happen? Yeah, you can eat. It's not that, but it will come till your esophagus and you will high chance that you will vomit it out. Similarly, here also, okay, there is a pressure 90 is enough to survive, but you are increasing the BP to bring it to a normal level. He had 120 BP, let me make it 120. Then as the pressure is more and more, bleeding also continues more and more. So you just keep at the baseline of 90 millimeter mercury. That is, nowadays this principle is called balanced or controlled or permissive. This much is permissible, this much is enough. So permissive hypotension, patient is in hypotension, that's okay, but this much is okay. It's not going to harm. This much of hypotension is, if it's less than 90, then it's harmful. Body is not getting enough blood supply. But if the blood pressure is 90, okay, body is getting the blood pressure. So this is called balanced or controlled or permissive hypotensive resuscitation. Okay, please know this. You need not have to set the BP always to the right. Even little lower than that is also more than enough. So that's about the BHR. Next, some trivial facts about the hemorrhagic shock we should know. Sir, please repeat the ratio once. Okay, very good. So for every pack, 1 unit of PRBC you give, transfuse, you have to simultaneously, you have after the one after the other, you should give one FFP, fresh frozen plasma, okay, which has got all the clotting factors and all. Then also you have to give platelets also, which is again required for the coagulation of the blood. Okay. So otherwise only there will be dilutional of the clotting factors and all. Only if you are giving only PRBCs, only RBCs will increase, hemoglobin increase, but there will be dilution of the clotting factors which are mainly present. So you need to give FFP also, platelets also in the ratio of 1:1:1. If you are giving 3 PRBC, then you have to give 3 FFP, 3 platelets also. That's the norm now. Is it clear now? Who asked that? Drishti, is it clear? Sir, please send the presentation notes after class. Sure, Vinita. We'll do that, okay? I will all annotated notes I'll send in the group. So, next, some things you should know about the hemorrhagic shock. That is, earliest sign, I told you it's tachycardia, and which are the other signs with which a hemorrhagic shock patient may come to you is cold extremities. The extremities, because of the vasoconstriction, body is trying to safeguard or avoid bleeding, so all the veins go into vasoconstriction, so temperature also comes down, so extremities becomes cold and calming. Sweating will be there, profuse sweating, and altered sensorium may be there as the patient goes into hypotensive shock. His blood supply to the brain comes down, so brain activity comes down, so may go into altered sensorium, drowsy, decreased pulse pressure, and hypotension. Hypotension is the last feature I told you. These are all the signs with which patient may come to you. Then how do you go about, how do you treat him? 2 things in all our trauma, all our surgery, this thing, we mainly decide anything, treatment depending on one common thing, whether the patient is stable or not. If the patient is stable, we can do all the investigations, we can do all the initial precautions, measure everything, and then do the definitive thing all at once. When the patient is unstable, you don't have any luxury to get the investigations done, waste your time in any way. You have to immediately intervene, whatever is required, the best. That is the criteria, whether the patient is stable or not. In all our discussion, further discussion in surgery, many things, most of the things depend on one factor, that is, if the patient is stable, this is my line of management. If the patient is unstable, this is going to be my line of management. Okay. Nami is asking when is the break. So yeah, it's 7:30 here. Okay, I'll 7:30. I'll finish off another few 2-3 slides, and at 7:30 I'll give a. Is it so boring, Nami? The class is so boring, or you want to take a break and you can't go without you don't want to miss the class. That's why you are confirming. How is it? Okay. So if the patient is stable, when the patient is stable, you can put two wide bore cannulas and then put a maintenance fluid, because patient is stable means he's not in a lot of hypotension, tachycardia not there, he's stable. Just put a maintenance fluid. What was a little bit of volume is lost, just compensate for that. You put a maintenance RL and then go for the next. After C, then you can go for the D. Okay, then go for the D. But when the patient comes with hemorrhage, remember, when the patient with torrential hemorrhage comes also, your first priority is airway only. Remember, first you have to check airway. He may be bleeding, but don't not just going and stop the bleeding. First check the airway, no problem. B, no problem. Then go for C. See in that, first initially secure the first always assessment, then the intervention, right? So first assessment is circulation. You in assessment only put two wide bore cannulas, then stop the bleeding. Hope it's clear now. Okay. Then put the IV line. First secure the IV line, put the cannula, then stop the bleeding. Third, start the IV fluids. This is the sequence, exact sequence. If any bleeding patient comes, okay, first airway, bleeding, airway and breathing. Then in the circulation part, first thing is insert the cannula, stop the bleeding, and okay, because without closing the gate wall, how much you fill the tank, it's no use. Okay, to close the gate wall, you need a secure, right? You have to secure the line, then close the stop the bleeding, then only start the IV fluids. It's the sequence. Hope it's clear, because many questions depend on this. They'll give a very commotion filled scenarios to you. They'll make you fully petrified, and question will be which is the next step, immediate next step is answer will be airway. Clear now? Okay. Telling nice class. Sir, please explain CPR. Definitely, doctor. I'll definitely explain CPR to you, and I'll make you do also. And Parajita telling class is interesting, sir. CPR and pediatric patients also I'll teach. Nice example. Okay, fine. So unstable patient, what do you do in unstable patients? What do you do? The patient is unstable. When do you call patient is unstable? Is when the BP is less than 90. Okay, when the patient is less than 90, when the circulation is not happening, traumatic circulatory arrest, all the blood, the body is not getting enough blood. It's called unstable patient. Then you can do two things. If the patient source of bleeding is, in the question it's given, bleeding is happening from the leg, or there is a hemothorax, something source is given, then you can directly, as I told you, you can secure the IV line and stop the bleeding. Okay, then you can start the IV fluids when the source of bleeding is given. Okay, there is a tamponade, there is a hemothorax, so they only give the source of bleeding in the question. Or sometimes in patients in real life, you can see if his entire floor is filled with blood, means some extremities bleeding is there. It's not internal bleeding, external bleeding, like that. If you have got a clue, then you can straight away stop the bleeding. But when there is not provided, you don't know where it's bleeding, then what you do is you straight away start with resuscitation, means balanced hypotensive resuscitation you start, then do some investigation to find where is the bleeding. You understood? Okay, when you can stop the bleeding, when it's evident, you stop the bleeding and then give the IV fluids. But if it's not told only where is the bleeding, from internal bleeding happening, features of shock is there, but I don't know where it is bleeding, then start the IV fluids, let it keep going. Then you do some investigation, X-ray, ultrasound or something, to know where exactly it is bleeding. That is the rule. Okay, then once you find out where is the exact site of bleeding, then I told you, if it's a hemothorax, what to do. If it's abdominal bleeding, what to do, I'll tell later in the abdominal trauma. Like that, you can do the treatment later on while finding where is the source of bleeding. Hope it's clear. Then there are something non-hemorrhagic shock also. Now whatever we discussed so far is hemorrhagic shock due to bleeding. Without bleeding also there can be some shock possible. There's something called neurogenic shock. I told you, if you move the spine erratically, it can lead to neurogenic shock, spinal shock. Okay, then there also patient present with hypotension. Instead of tachycardia, there will be bradycardia. Know that, that's the difference. Everywhere there will be hypotension. If shock means hypotension, that's a common thing. But there you had, because heart, the blood is lost, to compensate for the loss, there was tachycardia was there, but here the circulation is not a problem at all. Okay, so there is bradycardia and the circulation is happening, so you get what's it called, warm extremities will be there. Okay, what you can give is just crystalloids to improve the BP you can give, and some vasopressors, means I'll tell you what are those in detail when I detail in one conditions. What's cardiac tamponade? Somebody was asking. Cardiac tamponade. Tamponade means some pressure again. From external pressure is tamponade. Tamponade. Cardiac tamponade. It's a type of obstructive shock. Some obstruction is there for the heartbeat. Heart to contract and relax. There is some external force is there. What is that? Heart is covered by what, my dear friends? Please tell. Let me make you some more active. Otherwise, you're all worried about only break. What's heart is covered by a membrane, just like you told lungs is covered by pleura, heart is covered by a membrane. What is that? Heart is covered by pericardium, right? Pericardium, heart is covered by pericardium. So heart is beating like this and it's covered by pericardium, loose layer. If blood is heart is got injured or some aorta vessel is ruptured, all the blood is accumulated. So pericardium is filled with blood and it will not let the heart to beat like this. It cannot contract. So it is an external force is there. This condition is called cardiac tamponade. Hope it's clear now what's cardiac tamponade. So in this, what are the features are there? Like somebody was asking, how do you differentiate between tension pneumothorax and cardiac tamponade? Here in cardiac tamponade, they come with a classical triad of symptoms. It's called Beck's triad. Remember this question many times asked. What's Beck's triad? Three things. Hypotension will be there. Shock means lot of blood is lost, so they will have hypotension. And I told there is what is when the JVP will be increased, jugular venous pressure, there will be some obstruction to the inlet, the inferior superior vena cava, internal jugular vein, superior vena cava is coming and joining the heart. But because in the pericardium there is blood is filled and it is obstructing the inlet, so all the blood is pooled in the vein and vein get distended. So jugular, if the volume is more, the pressure is also more in the limited space. So JVP is raised, jugular venous pressure is raised. Okay, and when if the heart is not beating, earlier it was beating like this, it was contracting and relaxing like this. Now it's relaxing only this much. Can you hear the heart sounds properly? Heartbeat is because of the heart sound is because of the proper contraction and relaxation of the heart. Now it's not happening effectively. Can you hear the heart sounds? No. So muffled or absent heart sound you can hear. Okay, this is the triad of Beck's in cardiac tamponade. This is a must know. Okay, please. And how do you treat cardiac tamponade? It's also like your needle thoracostomy. Here you take a needle little longer in a subxiphoid window. Just xiphisternum, you know what is xiphisternum? Here the xiphisternum, just you palpate here, one bone is there, it's sternal bone. Just below that there is a empty space. Just below that there is empty space. It's called subxiphoid process. Subxiphoid space, subxiphoid window. From there, you take a needle, not yourself, don't try this at home. I'm telling to the patient with the cardiac tamponade only you can do this, or you can try on some mannequins. You insert a needle towards your left shoulder. Okay, when you little bit insert, it will directly go into the pericardium, and whatever the blood is collected there, it will come out through the needle. It's called pericardiocentesis. Just putting a needle and draining the blood is called pericardiocentesis. Initially, blood will be drained like that, the pressure will be relieved, but if the bleeding is continued, how do you know whether bleeding is stopped or not? Bleeding may be continuously happening there. So then you have to do the thoracotomy or sternotomy, open the pericardium and evacuate all the blood and stop the bleeding, and then close the pericardium. This is definitive treatment for initially you do minimum to save the patient. Then once the patient is stable and all, then you can do the definitive thing. At first only you should not go. Even now I have seen many dental doctors, when I go to them, they do the minimum things first. First when I go, they'll do the cleaning of the cavity and all. Then ask them to second time they do one level of filling. Then they'll put the, so step by step they do, right? Here also initially whatever required you do the first. Then you do the definitive thing. Not do no heroic, no what to say with full zeal doing the best thing at once. That's not possible here. Okay. So hope it's clear now. Tension pneumothorax, you already know that. Why is my stuck? Okay. Okay. Next is ABC is done. Then is D. Correct. ABC, airway, breathing and circulation done. Then the fourth part is disability. We are referring to the neurological deficits. So initially you do only focused neurological examination, only limited neurological examination. Entire detail you can do in the secondary survey. So first three things you look for. What is GCS? Glasgow Coma Scale. What's the level of consciousness? You will assess that. Second thing is pupillary reaction. You check for the pupils. You know, when you put light, it will constrict and then it dilates again. It's called pupillary reaction. Okay, whether it's normal or not, you check for that. Then there are some classical signs. It's called lateralizing signs. Which your side is a bleeding, it will show. You can see in the eyes only. It's called lateralizing signs. We'll discuss that later. So all these things, three things you check in the primary survey. If it is there, you have to intervene later. Or if it's not there, you can go proceed to the E, the last step. Okay. What is E? Is exposure. Exposure means if the fully patient drowned, you brought him to the surface, then because of the everything is exposed, he may lose all the his body heat get evaporated and he may go into hypothermia. Hypothermia also not good, so you have to cover him immediately and make him warm. So warm with blankets to prevent hypothermia. Anything fluids, anything you are giving, give at room temperature. Maintain at least temperature of 39 degrees Celsius. Okay. Then there is something called log roll. See, in front you can see everything. Exposure, everything can happen front. पीछे भी देखना है ना, पीछे देखो, पीछे तो देखो, पीछे बोलते हैं ना. So पीछे देखने के लिए क्या करना पड़ेगा, है ना? You have to you can't just push him that side and see the back of the body. There is a technique to move him to the opposite side. That's called log roll technique. It's called log roll technique. See, this is the log roll technique where 4 members should be there minimum 4 members. One is holding the head and see others are interlocking their hands and slowly moving like a log of wood. How do we roll it? Correct. That's why it's called log roll technique. Similarly, we roll the patient and look for the back of the patient, the back of the limbs, everything we inspect there in the exposure ABCDE. This is called log roll technique. Again, question asked. Okay, know this. What is log roll technique? Minimum number. That's also question. How many minimum number of people should be there? 4. Remember this picture. And one more scenario they asked, not for you, but in log roll technique only. It's a question. In case of lower limb fracture, to do the one extra person is required. It's 5 people. Okay, 5 people required for log roll technique with limb fracture. Otherwise, normally 4 people are sufficient. And last, before the break, I'll take one more slide. This is the question. Okay, last INICT also this question asked. They gave 4 options and asked which is not used in primary survey. So I'll ask the same question again at the end. Now know this, what are used, and then you can tell what is not used as a part of answer. Okay. So what are the adjuncts or tools used in primary survey? They asked the question. So first is to check for the saturation. We have many times told saturation is 85%, 90%. How do you know whether he is getting enough oxygen or not? You have seen, no, during COVID they used they always carried one instrument, that is pulse oximetry, saturation probe it's called, that you use. And ABG to know the blood gas oxygen levels. You can do a test called ABG from arterial blood gas. Okay. Then ECG is done. And X-rays, 2 X-rays are taken. Remember, in primary survey, one is chest X-ray, one more is pelvic X-ray. There is also in AP view. Usually, chest X-ray is taken in PA view, but in trauma scenarios where patient can't stand erect and all, then do bedside X-rays. Bedside X-rays will be coming from front to, it will go behind. Antero posterior, it's going AP view. Okay, only in trauma scenarios we do AP views. In other normal scenarios we do PA view of the chest, where we want to look at the lungs clearly. Then what is EFAST? Expanded focused assessment in sonology in trauma. EFAST refers to earlier only FAST was done. Nowadays we do EFAST. That's why it's called expanded. One more extra. It's included. Expanded focused assessment Sonology you know, sonography or USG, sonology in trauma, fast. This is done. Okay, I'll tell in abdominal trauma and all it's used to look into the abdomen, any fluid collection is there, any injury is there, look at that, you do this. Then I told you what is the best way to monitor the fluid resuscitation, whether you are giving enough fluids or not. How do you check? Is by urine output. How do you calculate every hour whether it's passing enough or not? By inserting Foley's catheter. That through the catheter in the bag, urine will be collected, so you can every hour you can monitor whether the patient has passed adequate urine or not. Then Ryle's tube orally for the feeding. When the patient is unconscious, you have to feed him something, so then you use Ryle's tube also for the decompression of the bubbles. Also it's helpful, as well as for feeding also it's helpful. Any collection is there in the abdomen, any bleeding is there, you will come to know by inserting the Ryle's tube into the stomach. Okay, so these are the adjuncts are used. So what the question asked to us, I'll ask the question now, please be ready. Recently last year only this question asked. Adjunct used in primary survey. First option was CXR. Okay. Second option was X-ray, pelvis. Third option was USG. Fourth option was CECT. Now tell me the answer. If you tell correctly, you can go take a break. If not, no break. Answer correctly and take a break. That's the best. Pericardium, everyone answered. Is there absent breath sounds here, sir? No, not absent actually. Darshan, it is muffled. Muffled means very faintly heard. Okay, faintly heard. In absent means is already dead. Heart is not at all breathing, which is not possible, right? So you can say muffled heart sounds. What is the next question, sir? What is ruffled or muffled? There's nothing called ruffled. I told muffled. Muffled means faint. It's very muffling. Like what we talk now, muffled. That's called muffling. Muffled heart sounds. Then Glasgow Coma Scale, Shilpa, I'll explain Glasgow. When I discuss a head injury, I'll discuss Glasgow Coma Scale in detail for you. So cute. You are funny, sir. Huh? Am I funny? Okay. Making surgery so interesting to learn. Okay, that's a good compliment. Even though I am funny. Yes, pulse oximetry. Sir, please explain fast again. Okay, I'll do that. Fast I'll explain. Anyway, in abdominal trauma, every step we come across this something called fast. There I'll explain again and again. I'll show you all the image, how it's done and all. I'll draw it for you. Yes, answer is everyone telling, oh my God. If Bhatia owner if sees this reply today, he'll be very, very happy. Okay, he'll be very, very happy. Because class has become so effective. All answer, not even single wrong answer. The entire this thing, not even single wrong answer is there. So what are the replies so adjunct used in primary survey? The question should be all except. Okay, all except. If the question was adjunct used in primary survey, answer would have been what most of CXR, chest X-ray, USG. This is right. If all except is option if the question, then the answer is CECT. You understood? No? Understood it clearly? CECT is because it takes a lot of time. It's not a part of primary survey. X-ray you can do bedside. Where the patient is, when the examiner is doing all the assessment, immediately you can do bedside assessment also. X-ray and USG you can do, but CT scan machine, can you bring it to the casualty emergency? It's impossible. So you have to shift him to the CT scan room. There you have to check any dye you have to inject. A lot of time it requires, minimum 1 hour. You don't have that much time in primary survey, right? So it's not a part of the primary survey. Hope it's clear now. And time is exactly 7:30. We started at 5:30. It's almost 2 hours now. Next I'm going to discuss about individual injuries. Okay, I'll discuss. Before that, one thing because I don't want to miss out this anyone. Damage control surgery. I have already explained about this. This is called damage control surgery. Means you do the minimum thing to save. Not the I already explained in multiple ways. You are not going to do the definitive things here. You are going to do only the minimum things to save the life. Okay, that's called damage control surgery, just to control the further damage. Okay, bleeding happening, just stop the bleeding. Don't do anything extra to which time is consuming. If there is some contamination, take away the contamination, source of contamination. You are not going to clean it completely then and there itself. No, this is called damage control surgery. What's triad of death? You should know. Triad of death, as any student, medical or dental, you should know what is triad of death. This says triad of death is, there is acidosis. I told you. Once there is ischemia, then as aerobic metabolism turns into anaerobic metabolism. If it continues like that, it will lead to acidosis, acid accumulation in the body. You know what happens if there is a excessive accumulation of acid in the body. Then there is coagulopathy. I told you, lot of fluids being given, your blood gets thinned, dilution. Dilutional effect is there, all the clotting factor, everything get low. Then the bleeding continues. If the clotting factor is not available adequately, then it will continuously bleed. It's called coagulopathy. And hypothermia. Hypothermia is again deadly. It can cause death immediately. Hypothermia. You should not allow the body to go beyond 35 degree centigrade. So these three things you have to break. This triad you have to break. Only then patient will survive. Any one of these continues, it will cause all three, then patient will die. Okay. So basic objective of our damage control surgery, if they ask, it's not the anatomical restoration which is important. Okay, physiological correction is most important. Physiological correction is more important than anatomical. See, a limb, if they lose also, still they can live. Anatomy, if there is a limb, you are no need to keep suturing the limb or a finger. If they or life is more important than the limb. Okay, I always say living problem is better than a dead solution. Okay, with some problems you can leave. That's better than a dead. You are given a proper solution, but patient is dead. What's the use? They say no. Surgery success, patient dead. What's the use of that kind? So you do minimum things to save the patient. What's early total care is patient has come. Now there is a injury. Yes, there is stab injury. Patient is bleeding. Just now started. I'm a surgeon standing right in front there. In front of me only this accident happened, and I have all my equipments ready. Patient has immediately come. There is no hypotension, there is no tachycardia, anything, because only started bleeding only. Then there only I can do the repair of the artery. It's called definitive treatment at once. But patient has come already after a lot of bleeding with hypotension and all. That time if I start suturing nicely, it's very time consuming, right? So that time I'll do only minimum thing. I just ligate the vein. I'm not bothered which vein, which artery it is. What happens? Maximum is some gangrene can occur. That later I'll take care. Okay. At the moment I do is I just ligate. I put some pressure or just ligate the artery and do the minimum things. Once the patient is stabilized everything, then I'll see if it is still viable. I will try to repair it. If not, gone. At least patient is alive. That's the concept of damage control surgery. The question was asked was, what's the most common complication of DCS? Since I am not doing anything very clearly, wound infection can occur due to damage control surgery. This is a question was asked recently. So that's why triad of death, please know this triad of death. And yes, we will take now it's 7:33. We will resume at 7:45. Is it okay? Take a 15 minutes break. 7:45 we will resume the session. Okay, head injury we will be discussing with all the images. I'll make it very simple for you. All kind of how to distinguish SDH, EDH, contusion. I'll make very simplified. Glasgow coma will be studying in detail. Individual you can learn to interpret the CT scans also. Okay, how to manage because that's a common thing as a maxillofacial surgeons you will be encountering all the facial injuries along with the head injury. How to manage that head injuries, I'll make you pakka or confident with. Okay, and I'll give you a lot of scenarios with exam questions only. If the patient comes like this, how to go about that. By that your concept also gets clear, and by solving that kind of scenarios or questions, your confidence also builds up. Okay, then neck injury, very important. Then one by one injuries we'll see, abdominal trauma, everything. And then after that, if time permits, I'll discuss about after crush injury. I'll discuss the burns also. Burns is yet another, you know in final year, in third year, you had burns as a major question also. In many question paper theory, university question paper, burns is asked major question. So that also we'll discuss if possible today till 9:30 we are having the class, or else in the next class we'll discuss that. Thank you so much. Take a quick break and come back by, now it's already 35, so at 7:50 we'll resume the class. Thank you so much for being so active and interactive and engaging. Thank you so much. Any doubts? Yeah, I will be in Telegram group. You can ask the doubts there also. Okay, you can ask doubts there also.